Thank you very much, Mr. Chairperson. Ladies and gentlemen, it is my great pleasure to have an opportunity to participate in this prestigious symposium. This is my disclosure information. Artificial intelligence is no longer technology of the distant future, but a technology that can be used today. The application of AI in the AF field is routinely carried out in the world. What I learned while applying AI over the last 4 years is that AI is very similar to the educating children. When they're learning with large amount of robust data, AI shows adequate predictive power, but it is difficult to generalize AI prediction if it is learned from limited or biased data. So in this time, I would like to introduce AI-related research that I have conducted with Yonsei AF ablation cohort. And the first model is the prediction model for LA wall stress. Atrial wall stress, stretching the left atrium, plays an important role in AF progression and remodeling. However, invasive left atrial pressure or LA wall thickness measurement are required to calculate this LA wall stress based on the law of Laplace. So we designed this clinical trial, and we calculated the left atrial wall stress in the development cohort over 2,200 patients, then developed a machine learning model to predict left atrial wall stress without invasive parameter or wall thickness. Finally, we applied and validated machine learning model in the independent cohort. We used these multiple clinical and echocardiographical variables for machine learning with conventional regression model using non-invasive variable. AUC for left atrial wall stress was just 0.66. After adding the invasive parameters, AUC increased to 0.72. By machine learning model with no invasive variable and no wall thickness, AUC for wall stress prediction was 0.73. As we expected, AF recurrence was significantly higher in LA wall stress group, and it was reproducible in the machine learning model without invasive parameter. And machine learning predicted a Q4 high wall stress group also shows a significantly higher AF recurrence at the independent cohort. So we concluded that the higher LA wall stress was associated with poorer rhythm outcome after ablation, and AI was able to predict this complex but useful prognostic parameter using non-invasive parameters with moderate accuracy. Let me get to the point of today's topic, AI-guided proper patient selection for AF ablation. This is Kaplan-Meier curve for AF recurrence after ablation in my institute, and over 4,700 patients, 1 year outcome looks good, but AF recurs continuously even after 5 years. So we realized that the AF could not be cured by AF ablation alone. However, most recurrent patients were relatively well controlled by antiarrhythmic drug or repeat procedure. In this study, the proportion of eventually failed rhythm control patient after catheter ablation was 3 to 8%. So I guess we could improve the outcome of rhythm control by excluding those patients who failed rhythm control. Then, does an AI predict poor responders who will progress to permanent AFib after ablation? In these, our previous studies, left atrial voltage correlated with atrial structure remodeling and left atrial pressure. And of course, low LA voltage is the independent factor for AF recurrence after ablation. Nevertheless, the problem is that we cannot acquire this prognostic parameter without an invasive mapping procedure. So we designed the clinical trial for the AI-guided prediction model that can predict the progression to permanent AFib after ablation. I apologize this busy slide, but we set up the development cohort with over 1,800 patients who underwent ablation, and we calculated star score by conventional regression model for permanent AFib progression. By utilizing the machine learning algorithm, we generate the AI model for star score. Then we validate our AI model at the independent cohort with 658 patients. This is STAR's risk model for permanent AFib progression. This score included previous stroke, AF type, LA dimension, PL interval, and left atrial voltage. Although LA voltage was a significantly powerful risk factor, it requires the invasive procedure. In the developmental cohort, STAR score well predicted AF progression, and the machine learning predictive model calculated the risk of AF progression without invasive variable and achieved excellent risk stratification with reasonable AUC value. Finally, the machine learning model successfully predicted the high-risk group for AF progression in the independent cohort 2. Therefore, using the pre-procedural and non-invasive variables, the AI prediction model can identify patients at high risk for progression to permanent AFib before the ablation procedure. So based on this study, we are conducting randomized clinical trial to test whether AI-guided patient selection for AF catheter ablation improves the rhythm outcome. We are welcome all of you to join this RCT IPAPA. And if you provide these several clinical laboratory data, echo data, and ECG PL interval, and AI calculate the risk of rhythm control failure within a minute. Okay, let me switch gear and move to the proper target selection in AF ablation. Although rhythm outcome of persistent AFib is not good enough, there is no consensus for the benefit of empirical axial PV ablation. STAR-AF2 failed to prove the superiority of electrogram-guided or linear ablations. Reaffirm also did not show the usefulness of rotor ablation. We also showed the negative outcome of additional electrical isolation of posterior wall in patients with persistent AFib and during the repeat procedures. Therefore, we realized that the empirical extra PV ablation do not improve the rhythm outcome of a persistent AFib ablation. A potential breakthrough of this hurdle might be the computation modeling guided targeting of precise extra PV AF drivers. Dr. Trianov group already developed the MRI LG-based AF modeling to target the proper ablation of extra PV foci as a proof of concept study. And we previously conducted the RCT with 118 patients with persistent AFib, and modeling guided the linear ablation improved the rhythm outcome of a persistent AFib ablation outcome compared with empirical ablation in 2017. However, we used the very primitive monolayer homogeneous QBR prototype model at that time, and the simulation was conducted before the procedure with cardiac CT scan. However, based on the advancement of computation technology, we conducted a prospective multicenter RCT for computation modeling guided real-time DF ablation in patients with persistent AFib. This is QBR-AF2 RCT protocol using computation modeling integrated by patient-specific voltage, conduction velocity, fibrosis, and fiber orientation. So at the beginning of the procedure, we acquired the voltage map like this, and then we integrated clinical mapping data to AF modeling, induced the virtual AF at localized dominant frequency site. We can generate the DF map within 30 to 40 minutes during the PV isolation procedure. After PV isolation, modeling guided mapping information is given to the operator for the additional ablation of the dominant frequency site. This is synopsis of QBR, reflecting personalized anatomy, histology, and electrophysiology. At the beginning of persistent AFib ablation, the clinical team acquired the voltage activation map and send the EGM data to the core lab, and core lab integrates the clinical map of AF modeling reflecting fiber orientation and fibrosis map. Then we induce virtual atrial fibrillation to localize DF area and it takes the 30 to 40 minutes for the computational. In this study, we included 222 patients with persistent AFib in QBI-AF2 trial. Among the included patients, 23% were excluded due to failed cardioversion or reinitiation of atrial fibrillation. So restoring sinus rhythm to acquire the electroanatomical map is the major limitation of this study. However, over 170 patients were included and randomly assigned to virtual DF group and the empirical pulmonary vein isolation group. These are the examples of dominant frequency ablation. This is a virtual DF group case with extrapulmonary vein dominant frequency here, and we conducted additional ablation for DF sites after PV isolation. This is the outcome of QBI-AF2 trial. Computational modeling guided additional DF ablation showed a significantly superior rhythm outcome than empirical ablation in the patient with persistent AFib. Now we are conducting another RCT targeting extra PV phase singularity points, and you can appreciate the AF termination during the phase singularity points on anterior mitral annulus area in this specific example. We hope we will be able to report the outcome of QBR PRR next year. Yeah, termination. The next step is convergence of AI and CT integrated modeling data. And by using multi-view convolutional neural network, we can train the morphology of left atrium by AI. Because our AF computational model, QBR, is constructed based on CT images, we can train not only LA morphology, but also wall thickness, activation, voltage, dominant frequency, rotor, and the restitution. So these complicated AI calculations will be put together by ensemble model, and eventually will predict clinically useful outcome data, hopefully. Okay, in conclusion, ladies and gentlemen, AI predicts LA wall stress, which has a prognostic value after catheter ablation by using pre-procedural and non-invasive variables. Using the pre-procedural and non-invasive variables, the AI prediction model can identify the patient at higher risk for progression to permanent AFib, even after catheter ablation before the procedure. Cardiac CT image-based AF computational modeling output will be utilized to train AI as an ongoing project. And finally, artificial intelligence is a very useful and smart diagnostic tool in AF management, including catheter ablation. Thank you very much for your attention.